Hello, my name is Dr. Payal Kohli, and I'm a cardiologist who specializes in non-invasive and preventive cardiology. I graduated from Harvard Medical School, and I currently own and run a general cardiology practice in Denver, Colorado. And today, we're kicking off a series where we're going to tackle 5 common misconceptions surrounding the use of coronary CTA, or coronary CT angiography, which is a test that has become a mainstay of diagnosis for coronary artery disease. One common misconception that I often hear from my colleagues and my referring providers is that stress testing is the gold standard for diagnostic tests when they have a patient with suspected coronary artery disease. Now, this may have been true some time back, but it's no longer true. And let's dig into why that might be. You have many options when it comes to testing for non-invasive cardiac tests, and many of us have historically started with an exercise treadmill test or a SPECT when we see patients who might have symptoms like shortness of breath or chest pain or something that could suggest that they have coronary artery disease. However, it's time for a wake-up call because times have changed and stress tests and stress EKGs are no longer the gold standard per clinical guidelines. In fact, in 2021, the ACC and AHA updated their chest pain clinical practice guideline and placed coronary CT angiogram as a Class 1 recommendation with level of evidence A. This supports the use of this pathway for intermediate to high-risk patients with stable chest pain and no known coronary artery disease. Now, this update is huge because it really represents a paradigm shift from other non-invasive tests to what we call a CT-first strategy to diagnose CAD and to guide our treatment choices. Now, you may be asking, why are we still relying on outdated tests for diagnosing coronary artery disease if they provide an incomplete picture? Well, for the benefit of our patients, we really owe it to them and to ourselves to investigate these updated clinical practice guidelines and learn how to pivot and change our behavior so that we adapt to the updated scientific evidence. Now, the cool thing about a coronary CTA is that even if there is no obstructive disease, it can give us a lot of information about the extent, about the burden of atherosclerotic plaque, so we can start to think about statins and being more aggressive with our preventive measures. Now, other testing modalities also have high rates of false positives and false negatives, and this can lead to multiple other layered tests or unnecessary invasive procedures. This obviously is very inconvenient for our patients. It can delay their therapy, it can be expensive, and it could have been avoided altogether had a better test been chosen to begin with. So let's compare coronary CTA with one of the common tests that we order, which is SPECT. Coronary CTA consistently shows a better diagnostic performance when compared to SPECT in patients who don't already have known coronary artery disease. In the CORE 320 study, coronary CTA and SPECT diagnostic accuracy, sensitivity, and specificity were prospectively compared head-to-head. And the sensitivity of coronary CTA, because it's an anatomic test, was notably better than SPECT at identifying disease. In fact, coronary CTA outperformed SPECT by almost twofold when assessing the test's ability to detect CAD. Now, you may be asking, well, which patient should I start thinking about a coronary CTA first? And how do we really get ourselves to change our behavior from ordering those stress tests that we're all so comfortable ordering? Well, in patients who present with chest pain or an anginal equivalent, but they're stable and they have at least an intermediate pretest risk for coronary artery disease, those are the patients that are generally the best for getting a coronary CTA. And in my practice, I often order a coronary CTA first, especially in my women or in my elderly patients if their renal function is normal, and also in my South Asian patients because South Asians can have premature coronary artery disease. So let's recap. The misconception that we often fall into is that stress testing is the standard of care for diagnosing coronary artery disease for our patients. Hopefully, today I've debunked that myth by showing you that the chest pain guidelines recommend coronary CTA as the only Class 1A test for suspected CAD patients over other non-invasive tests, making the CT-first strategy the new paradigm for non-invasive testing. Be on the lookout for other videos debunking other misconceptions regarding the use of coronary CTA. After all, we went into medicine to do the best for our patients, and this means keeping up with the latest evidence and changing our behavior accordingly.